Hi, I'm Jennifer Graham. The problem that I want to talk about is nurse patient ratio staffing versus workload and acuity staffing. So, an overview of my community. So, the community in this sense is my mother baby unit that I work in at Salem Hospital. It is the Family Birth Center, located in the Family Birth Center, which has been in operation since 2003. The mother baby unit has 26 beds, and this is for 26 mother baby couplets, which is a mom and a baby, is a couplet. There are between 265 and 280 births per month, and approximately 27% are C sections or cesarean sections. The NICU is classified as level 3 and takes babies down to 26 weeks now, according to our website. It is a magnet facility, and we recently have been designated as baby friendly as well, which is a designation for breastfeeding rates, support breastfeeding, and breastfeeding excellence. We do currently have 52 RNs and 14 CNAs on our staff for the mother baby floor, and that's for nights and days. And we do have 2 to 3 lactation consultants each day that are on the floor during the day, not at nighttime, but they are on the weekends. And we do have a birth certificate clerk during the week, Monday through Friday as well. Our management includes 1 nurse manager and 3 assistant nurse managers. The culture of our unit is based on kind of how our hospital has changed throughout the years with our excellence. So, the mission at Salem Health is to improve the health and well being of the people and communities we serve. And you can find this on our website. Our values are excellence, accountability, integrity, caring, and teamwork. And we do have a professional governance body in our hospital, and that culture has grown throughout the hospital in the last few years to have shared leadership. So nurses feel like they have more of a voice now than we did previously and can be a part of positive changes in our hospital. So there is a lot of evidence-based practice changes that come about because a lot of the forefront nurses that are part of this professional governance, they do research their specialties and see what the latest research is and make changes based on those current practices. We do follow lean and Kaizen principles, which is in essence, how can we make this better? That's how I think of it, anyways. So basically, anything in our day that we think is not working like it should be, or that is creating waste in our environment, wasted steps, wasted time, anything that we can do better, then we are encouraged to do a project to work through how to make that better. And some nurses are not as engaged as others. I think you will find this anywhere. But there has been a growing number of staff that are more engaged now than there used to be. I have been there for 14 years, so I've seen the change throughout the years, and it has gotten quite a bit better. There are some day shift and night shift rifts, and again, I think you will see this anywhere, but a lot of night shift didn't do this, day shift didn't do that, why did they leave that for me? That kind of thing. You still hear that a little bit on our floor, although we do try to work together and communicate and try to assume good intent with each other. And there is an unspoken culture that if you're sitting, you're not working. So a lot of times I will see nurses sitting down to chart, and someone will come up and ask them to do something, or we'll just assume that they're not busy because they're sitting down. When in essence, we all know that charting is a big part of our job, so it does take a lot of work to catch up and chart what we have done throughout the day. So that's something that's not positive on our floor. And another culture fact is that nurses are committed to excellence, and we're protective of our mother baby couplets, and we want them to have a great experience in our birthing center. So we are very, very protective of our couplets. We want to provide very good service. We have been rated best place to have a baby in the Willamette Valley, which is in Oregon, for the last couple years, and there are quite a few birthing centers around. So we take pride in that, and we want to make people feel like they want to have their baby here. And because of what we do, our area is mostly women dominated. We do have a few males in our area as far as the float pool, which is our maternal child float pool. They float between mother baby, NICU, and pediatrics. And we do have a couple of males there, and we try to make them feel welcome and like they are professionals and part of our team as well. But mostly women that we work with on our floor. So, the issue that I want to tackle here is that nurse to patient ratio based staffing might not be the best way to plan for and staff our nursing units. So, currently, our mother baby unit staffs with a one nurse to a 3 to 4 couplet ratio. And this is to try to be in accordance to what the Association of Women's Health, Obstetric, and Neonatal Nurses, otherwise known as AWON, recommends, and that's a 1 to 3 ratio. Basically, it gets a little tricky because we don't want to be over budget. So if there's a nurse that has 2 patients at all, we can't do that because that would be overstaffed with the current way that we do it. So then we would have to disperse those 2 couplets to different nurses. So then they would then have a 4th couplet. So nurses are feeling increasingly overwhelmed with the workload on our unit, and they're starting to experience burnout. And these are just things that I have heard around the unit. I do sometimes function as a charge nurse on my floor, and I do hear a lot of feedback as far as nurses being overwhelmed, feeling like they are very busy and that they don't have time to take their breaks and they don't have time to do what they want to do as far as breastfeeding help, and all those kinds of things that we are supposed to be doing as mother baby nurses, all the education that we do, and that kind of thing. So, how this issue has been dealt with in the past. Charge nurse is available to assist as needed. We don't typically take a patient load unless absolutely necessary. And that is so that we can be available to help with emergencies on the floor, assist where needed, just help with anything on the floor that our nurses are needing help with. The CNAs are on the floor to help with delegated tasks, although recently that has been um, a little short staffed recently. Usually we have 2 CNAs on the floor when we have over 15 couplets. And that's a lot of patients per CNA. So mostly they would focus on getting birth certificate data collected and helping with that and paternity if need be. So they're responsible for that, and they do baby baths, they do vitals, they can empty Foley catheters, they can get water, take out trays, change beds, that kind of thing. And if you think about it, that those kind of tasks, if they're not done by the CNA or we don't have a CNA, are then pushed back on the RN. So that's even more tasks for the RN to complete during their shift. We did have an admit nurse role at one point, and a lot of floors in our hospital, med-surg floors, have a resource nurse that is there to help with things on the floor. And that's kind of what our admit nurse was back in the day when we had it. Basically, I did this role too, actually, at one point. So we would come in for the day and we would go to labor and delivery and see what the deliveries were for the day. We would be present for C-section deliveries that were planned because we would basically be the baby nurse at that point. We would help admit the baby. That's why they called it the admit nurse. And then we would help with other deliveries on labor and delivery as far as babies, like doing the weight and the medications like the vitamin K and the eye ointment and doing the measurements and all that stuff. we would help with all that. And then if we didn't have deliveries, then we would go back up to the floor and just help where needed or be in the nursery if there was extra babies to watch. So we did have that at one point, and I think because of budget, they got rid of that again. So we don't have that anymore, but that was something. And then recently we trialed having a discharge nurse because we were working on a project on how to get our discharges out quicker. And this was one idea that they thought of. So we did trial having a discharge nurse. The only downside was that we didn't increase our staffing, so it made nurses have more patients on the floor, and then the discharge nurse would help specifically with discharge teaching and getting people out the door. But it wasn't very well received. People just felt like they wanted to take care of their couplets, but it was too overwhelming to have more. So they stopped that shortly after the trial. We do assign break buddies to cover for shifts for breaks and lunches. Sometimes that doesn't work too well because everyone's busy all at the same time, but that's what we got at the moment. We do have a respite room with a massage chair and a foam roller and yoga mat for staff to unwind if they do get a break, if they can get a break. And we have several of them throughout the hospital, and that's a project to help with nurse burnout and just to kind of help nurses feel like they can unwind a little bit during their shift. So that is kind of nice if you can get to it. So why is this issue a problem? Well, management and hospital leadership determine the budget for each unit, and the hospital budget is increasingly limited with the government regulations, and we all know with Medicare reimbursement and how that has all changed, how it impacts the budgets of the hospital. We have to be very tight and try to cut waste while we can, wherever we can, to just help with the overall budget. RN staffing has the greatest impact on each unit's budget because that is where we spend the most money as a hospital, is paying our staff, and RNs make up the biggest percentage of staff at the hospital. So appropriate staffing is extremely important for the budget. So not being overstaffed at all is very important. And our unit rates fairly high with patient satisfaction according to Press Ganey, and safety. And you can see on the right there is our most recent Press Ganey scores for overall obstetrics. That's for labor and delivery and mother baby. But so we rate pretty high compared to other hospitals for patient safety. So I see this as an issue because management or in leadership might not find a need for an increase if we're already high, I guess. And then it's hard to show data for a risk for patient safety and experience related to understaffing because it's a risk. And so you don't have any data for a risk for something. So what we can do is pull research that is out there to show our management to hopefully help them see the benefits of changing. The social impact. Because this is a mother-baby unit, it's not going to socially impact my community all that much. But the social impact on our floor, the charge nurses on our floor have a lot of the same concerns. The nurses are overworked, and our current way of staffing is worrisome for patient safety and throughput. The discharges take longer than they should because nurses are busy, and the admissions and discharges throughout the day add stress to the floor nurses, all the ins and outs and taking over new assignments towards the end of the day and that kind of thing. The assistant nurse managers and the manager are very open to problem solving this issue, so that is encouraging. They do want to help make things better for us. We're all in this together. But they are reluctant to increase staffing without very good reason, and that is because what I said earlier with RN staffing and overstaffing being a major impact to our budget. So there is impact to patients, obviously, when you have a nurse to patient ratio type of issue. So going from a nurse to patient ratio to a workload acuity staffing does have an impact because research has shown that it has improved the patient experience, it has improved breastfeeding support, and it has improved safety. So I did find quite a few articles. I picked a few there as my resources. The improved breastfeeding support was not directly related to workload acuity staffing, but it was related to greater staffing or better staffing in the NICU being linked to more breastfeeding support for moms. And I think that has a pretty good correlation to our population as well, and being able to actually fully support our breastfeeding mothers to make sure they get started on the right foot. So in analyzing this issue, there are some strengths that our mother-baby unit have related to this issue. And one is that staff are very good at helping each other in emergent situations. They all rally, they all help, and get everything taken care of that we need to. If there's an emergency like a hemorrhage on the floor, all the other nurses, if they're not directly helping that nurse, they will help to cover the other patients of that nurse just intuitively. Like they don't have to be asked, they just do it because they know that they know what it's like and they know that they need to help each other. So that is one good thing we have going for us. Another strength is that more staff are more engaged with problem solving processes now. Because it is required to complete a lean activity or be part of a 4-step problem solving project now every year with our annual review. So more people are kind of forced into being engaged, which is good because once they start, they realize that it is a good thing and they usually continue. And so we may be more invested in a project to help with stress felt on the floor because it does directly impact all the nurses. So I do feel like a lot of nurses will be supportive of a project related to this issue. The weaknesses of the mother-baby unit related to this issue, sick calls, leave of absence, and vacations can sometimes hinder how much staff are available on a given day if it's busy. So even if we are calling for more nurses based on a different staffing workload acuity staffing tool, we may not even have the nurses to call on. It has been a little tight sometimes, but again, we do have to balance our average daily census because we don't want to be put on standby if we're overstaffed different times of the year. So that is a balance that can be hard sometimes. Another weakness is the charge nurses feel obligated to go by the grid for staffing, which is a grid for basically the ratios of the nurses to patients based on the census numbers. And if they are overstaffed more than a couple times, they will get talked to by management for that. And no one wants to be called into the office. CNA coverage is currently low as well. I did mention that before. They typically we've been one CNA short several times during the week, during the day, and at night they've been short more often than not. I think they just hired a few more CNAs on nights, but it's been a little dicey with our CNA coverage recently. So what I would recommend doing for this issue is going through the 4-step problem solving process that our hospital has in place for these kinds of problems. This process helps us find the root cause of a problem, and then we can create a test of change to try to solve it. So in going through this process myself, I have discovered that another unit was having similar issues and tried a workload acuity tool to assign patients more evenly to nurses. And they've had really positive feedback from this experience. So we may be able to adapt this workload acuity tool to our unit to try to replicate the process. For funding for this issue, it will depend on if our tool is saying that we need more staff or not. If it does, then the funding can be hopefully rationalized to come from our potential decreased readmissions. better outcomes for patients and lower staff turnover due to burnout. And we can give them some research that we found on how having better staffing helps patient outcomes, helps with safety and patient experience, helps with breastfeeding support, and all those things that I found. And all those factors would most likely even out any increase in spending on RN staffing. Here is what the four-step problem-solving process looks like. It's basically a form that you fill out. They do have some Kaizen representatives that can help you if you have questions, but basically our big general was concern was that our nurses were feeling overwhelmed during their shift, and that's kind of how this whole thing came about. So I went through and kind of went through what should be happening just based on talking with other nurses and getting a good idea. Me and a few other people did survey our staff and just asked them how they would rate their shift on a scale of 1 to 5, 1 being horrible, 5 being a really great shift. And we basically want nurses to rate their shift at a 4 or 5 each day to be a pretty good day. And only like 56% of the time they were rating their shift at 4 or 5, which is pretty bad. So we thought maybe 80% would be a good number to shoot for there for how often nurses are rating their shift at a 4 or 5. And that gap then is 24%. So, and then step 2 would be finding the root cause. So we go through and we ask, when does this happen? And then we find a direct cause, which would be, we decided imbalanced workload would be kind of something to shoot for there. And then you go through whys. You ask why over and over and over until you get to the root cause. And we found that the root cause was an inadequate system for assigning patients evenly. So that is why we came up with the acuity workload tool and staffing as a potential problem solver here. So the hypothesis is if we have a system for assigning patients evenly, then we will have nurses rating their shift at a 4 or 5 at 80% of the time. So here is an example of the workload acuity tool from another unit at our hospital. You can see that it's from med telemetry. You can see that 1 is rating a patient out of 1 is a stable patient. A 2 would be a complex patient, and then 3 would be a high-risk patient. 4 is extreme risk, so you'd probably be transferring that patient at that point. But basically, they've given different indicators for clinical severity and then nurse workload indicators as well. And even though this is regarding a med-surg type patient, I think that we could implement something like this for our moms and babies for Mother Baby. So my recommendation is to create a workload acuity tool for predictive staffing and workload leveling for Mother Baby units. Basically, we can look at this further and figure out the details, but charge nurses communicate with the staff nurses to determine the workload acuity number for each patient and couplet, so it would have to be moms and babies. And then the charge nurse totals the number for the whole unit and then could staff predictively for the next shift based on the workload and the incoming procedures like C-sections that are scheduled soon, people that are about to deliver, that kind of thing, can staff for the next floor based on what the total workload is on the floor instead of the actual number of patients that we have. So then the charge nurse would assign patients based on the workload acuity instead of the number of couplets. So instead of assigning just 3 couplets or 3 to 4 couplets per nurse, we would be looking at what's a good total number of workload and acuity that each nurse should have, and then break it up more evenly that way. So here are my references. The AWHONN guidelines are from 2010, so that's a little older, but that's the most recent thing they have for staffing guidelines, and that's what we've been using. So obviously, we need to update the way that we're staffing, right? And then these other ones are more recent. Thank you.